physiotherapy students currently on placement with sort of on a split placement between the AHP faculty and the MSK patients. So I won't get anyone to introduce themselves because we might be here for a while. So I know we've got people from the MSK team watching, as well as some senior staff and then staff from our universities. And then we've also got Nisha, Charlotte and Graham who we're working with the faculty. So the presentation will be recorded if that's okay with everyone. No one's got any issues. And if everyone could just make sure that the mic's off, that'd be great as well. We'll have an opportunity at the end to ask any questions. So when the time comes, you can just put your hand up, press that button, and then we'll just try our best to answer any questions. And if you need to leave during the presentation at all, then that's absolutely no worries. You can just get off. Okay, so what is the CNM AHP faculty? So some background on the faculty if anyone is unsure or unaware of what the faculty is. So the Cheshire Merseyside AHP faculty is sort of the engine room for the Cheshire Merseyside AHP Council. And the council's made up of AHP leads who decide on what the main issues facing the AHP workforce in the Cheshire Merseyside area are. And then they'll try and resolve these issues by employing project management and quality improvements approaches, and they design projects to sort of test out ideas. So it's a collaboration between sort of all healthcare sectors where AHPs work within Cheshire and Merseyside, which includes NHS providers, local authority and social care, higher education institutions, and also like independent and voluntary sectors. So alongside the current project that Ellie and I are going to be talking to you about today, the faculty is also currently involved in quite a few other projects, which is listed here. So the continued development of the faculty, the Workforce Stabilisation Project, and then also the Northwest Placement Capacity and Demand Project. So if anyone's sort of interested in working with the faculty, I've just listed a few benefits from doing so. So all the faculty members come from existing AHPs working within all the organisations that I mentioned before. And they all come from different backgrounds, bands and levels. And these members are passionate about collaborating and developing the AHP workforce and resolving any issues that are sort of widespread. So anyone who's particularly interested in developing their leadership, project management or quality improvement skills, then working with the AHP faculty will be really beneficial. I've just listed on the right a few ways to find out more information regarding the faculty if you are interested. So there's the Twitter account there with a few sort of relevant hashtags, and then there's also Nisha's and Graham's email address as well. Okay, so what is the Clinical Expansion Placement Project? So the aim of this project is to increase the number of AHP students on placements across Cheshire Merseyside NHS providers by about 100 within the next year. And then that's across all of these 10 professions that are listed there. And Ellie will tell you in a second about our specific role in this project that's currently underway with the faculty. And so why is this project needed? So there are currently more AHP students in sort of higher education institutions than there are clinical placements available to them. And this has led to the need to increase placement demand with limited supply, really. The project allows more placement opportunities to cater for this increased demand. And this demand primarily stems from the national need to increase numbers of AHPs by 27,000 over a 10-year period in order to meet the demands of a growing population with evolving healthcare needs. And all this is detailed within the interim people plan and the NHS long-term plan. So in order to do this, we need to increase the number of AHP students on placement, and to do this, we need to have the means available to provide them with adequate placements. And over the past year and a half, this problem has been exacerbated by COVID, and a lot of the placements have been cancelled, and it's created quite a bit of a backlog. And obviously the problem still remains. It's getting a lot better as we come out of lockdown and stuff, but there's still reduced space sort of with social distancing, students and educators needing to shield, sort of cancelled or reduced patient appointments or like face-to-face. And then obviously staff redeployment in certain areas of the NHS being quite overstretched. So these are the primary reasons why this project needs to take place.
So our role within this project, so we're completing our own project within the wider context of the CPEP project. So in order to do this, we use the model for improvement, which is a key aspect of quality improvement projects in order to develop and plan for our own individual projects. So this consists of two parts, and you can see the diagram just on your screen there. So we have the framework, which is those initial 3 questions that helped us to develop what we wanted to achieve and think about how we could measure this. So these are: what are we trying to accomplish? How will we know that a change is an improvement? And what changes can we make that will result in an improvement? And then the second aspect of this is the PDSA cycle. So plan, do, study, act. And this is kind of the engine work of a project. So this helps us to actually think about what steps we need to take and how can we test if they're doing what we want them to do. So to start with, we focused on those initial 3 questions. What are we trying to accomplish? And this is how we developed our project purpose. So our purpose was to develop and present strategies to enable the musculoskeletal outpatients physiotherapy team at St Helens and Knowsley Teaching Hospital NHS Trust to offer a 2 student to 1 educator, so a 2-to-1 model of placement delivery for September 2021 in order to increase the overall number of students that they are able to take in 1 year. So I know that maybe some people haven't particularly heard about the 2-to-1 model before, so it's essentially what it says on the tin. It's where 2 students have 1 educator, and this is already being used in other professions such as SALT and within physiotherapy in other trusts and departments within the region and the wider UK. So within the development phase of our project, we continue to use the framework to take that project purpose and to develop our project aim. So this had to be a SMART goal, so specific, measurable, achievable, realistic and timed. And this was kind of the same as our initial project purpose, but basically to develop and present strategies for the implementation of a 2-to-1 model of placements for the MSK outpatient physiotherapy team at St Helens and Knowsley Teaching Hospitals NHS Trust by the 23rd of June 2021, which is what we're doing right now. And then we broke this down further into the following objectives to kind of direct our project plan and to develop our ideas. So this was to define the current problem and the need for implementation of the proposed model using semi-structured interviews with relevant stakeholders, and then to determine appropriate strategies for the implementation of a 2-to-1 placement model in the STHK MSK outpatient physiotherapy team, present the proposed strategies to the relevant stakeholders, and then collect data on the clinicians' attitudes before and after the presentation of the proposed model. So these are kind of the steps that we were going to take in order to achieve our goals. So this is we use this further to develop our driver diagram. So this details why this specific project is needed and what's sort of driving it forwards. So some of these are kind of similar to what Callum's already talked about in terms of the wider CPEP drivers, so I'm not going to kind of repeat what he's already said. The main point to look at on this side is kind of this bottom point of the specific drivers for the department. So that the fact that the SCHK physiotherapy department currently only takes 1 student at a time. So then if we break this down further into our secondary drivers, we know that obviously it's part of this regional incentive that the CPEP project has to increase AHP placements across the region by 100 additional placements. So obviously this department is a part of that, and we need to think about how we can do this. There are current views within the department on their capacity for students, so staff feel unable to take more students due to clinic structure, staffing levels and timetabling, so we want to think about this. And there's also opportunities for increased recruitment. If you have more students, then they may be potentially more likely to want to work with the trust in the future, which is a big driver for them. So we therefore, referring back to our model for improvement and our objectives, we decided to do some data collection in order to really help us to define the problem based on the views of the stakeholder and start doing those PDSA cycles of presenting our project plans to the stakeholders and getting their feedback. So we conducted semi-structured interviews, and this was in order to understand the current barriers in place and explore educators' perceptions of the model so that we could appropriately target our project and the plan plans that we were making to the specific challenges and needs of this department, and also to receive feedback on potential strategies for implementation. So we wanted to present some ideas, and it was an opportunity to gain a better insight into some of our plans. We also conducted an online survey, so we developed a SurveyMonkey questionnaire that was distributed to the whole team, and this was in order to understand their perceptions of the placement expansion and the 2-to-1 model, and also to use as an objective measure to compare perspectives before and after the project. So this was sort of the main outcome measure to determining the project's success in altering perspectives. So with our aims in mind, we developed an interview sheet and therefore conducted interviews with 4 Band 6 physios who were all involved with students, and also with a member of the management team of the department. And we collated their responses and summarised them in order to develop our barriers, benefits and problems, which we'll be detailing later in the presentation, so I'm not kind of going to repeat myself. So a general summary of the interview responses is on the screen, so we made it into this word cloud here, and this was particularly focusing on the team's perspectives of the barriers and just their perception of the 2-to-1 model. And as you can see, their main concerns were about increasing the workload for educators and the challenges of splitting up patient caseloads in clinics evenly to make sure each student gets enough clinical experience. And there were concerns about being able to provide enough support to both students, and you can see that from kind of divided attention, less support, and like the split caseload and potential reduced quality of placements.
Yeah, and as Ellie stated, we also created an online survey that was distributed to the MSK team. This was just to determine the common opinions and themes from the teams regarding the 2-to-1 model. And this survey we'll be sending out again after this presentation, just so we have an objective measure and see if anyone's perspectives or opinions changed. So we have many questions in the survey, but we've decided to focus on these 4 main points. And the contrasting answers on the first 2 questions were quite interesting. So we asked, do you believe if the department has the capacity to take on more physiotherapy students? And everyone answered yeah. But then when we asked if, as an individual, do you feel like you have the capacity to be in a clinical educator for 2 students at a time? And everyone answered no. So this was quite interesting, and we interpreted it as the team would be more than welcome to have more students at once, but maybe feel more comfortable if they were spread across the team or in the 2-to-1 model. And this is still a welcome insight for us, really, that you're willing to do this, and it's also something that can be implemented using the strategies that we're going to talk about in a bit, in order to increase the students on the team. And then also we asked the reasons why the team chose no, and also what sort of strategies would help ease the pressure of having 2 students at once. And then we'll go on to talk about these answers in a sec.
So using both the interview and the survey responses, we developed some potential barriers to kind of think about when we were thinking about the implementation of the project and the 2-to-1 model. So the first one was the working patterns within the department. So the clinicians work 4 days a week. So they were concerned that they would need like cover for those days. There's virtual fracture clinic, which potentially they wouldn't want the student there all the time. And they're split across the 2 sites. So it's more difficult to share the caseloads and share work with others. The organisation of patients into clinics, so students always need to be working with one clinician because each clinician has their own clinic. There's not sort of a student list, and this ties into those difficulties with working patterns. So if the clinician isn't there, there isn't a clinic for the student to be a part of, which is very different to like the wards. The patients are always there, even if your educator's got the day off. The division of the caseload. So in a similar vein, if the students are sharing a clinic, then they would get less clinical experience or opportunities, less patient mileage, stuff like that, which people were quite concerned about. A very big kind of issue that was brought up was the splitting of support and education between those 2 students. So the educator would need to divide their time between the 2 students, which therefore increases the workload for the educator and or means that there's going to be less support for those students. And all clinicians that we interviewed felt that having less support would reduce the quality of student placements. There's also a lot of variation between students, so no two students are the same. Each needs their own individual support and guidance. And then a big issue that was brought up was the potential for maybe a stronger student to receive less support if paired with a student that requires a lot more of the educator's time. This could potentially reduce more comparison into marking, making it less fair, and could reduce one student's confidence if they're always being compared to or always comparing their self to another student that maybe has more experience or more confidence than them. The increased workload of clinicians. So this is particularly linked to supervision and marking. They felt that having two students would obviously double this workload, and physical space within the department. So particularly with COVID-19 and the need for social distancing, this makes an issue. And often there's some issues with having like enough computers for notes and things like that. So this was all things we needed to think about when we were developing our strategies.
So the opportunities and benefits of having more students and potentially implementing the 2-to-1 model we just listed here. So for the placement provider, it allowed more students to take on workload, and you can expand clinics. So you can bring in more patients and be able to distribute them to the students, and then patients would be seen a bit quicker. And then training education can be done at the same time between students, and it also encourages recruitment into the trust if you're having more students with you. And then as well for the students, I think opportunities for peer support, and also protected time for learning. I think they're really big ones that myself and Ellie have sort of benefited from with this placement. And also you still be able to get the right clinical hours, and then increased use of technology within the clinical practice as well. And then for the profession, so educating students also encourages the clinicians and their educators to review their own knowledge and clinical reasoning. The students will still graduate with enough clinical experience to be competent physios when they're qualified, and also paves the way for expansion of courses to increase capacity and increase the number of clinicians. So as Ellie said, with the potential barriers really from the feedback, we decided to focus on 4 primary problems that we've come up with strategies with. That sort of the clinicians believe will hinder the 2-to-1 model and the students' experience. So these are reduced clinical opportunities, so splitting educators' sort of caseload between them, not having enough patients to see. Increased workload, so on top of sort of busy patient caseload, educators would have increased student marking, assessments, feedback and stuff. And then staffing levels and timetables. So the physios and the MSK outpatients team usually work 4 longer days per week. So obviously if students were to be with the educator on the working days, they'd have to fit everything into these 4 days. Whilst they also have other tasks to complete, such as virtual fracture clinic and supervisions. And then finally, sort of the variation in the students' abilities, which Ellie's covered. So the abilities, the confidence and the methods which they learn best, it might be difficult to sort of equally split workload and attention between 2 students if they are at different levels.
So what can we do to solve these problems? So the Cheshire and Merseyside AHP faculty have developed a toolkit which will help placement providers to take on more students and expand their placement opportunities. So the toolkit involves a number of different approaches, and these can all be utilised and tailored to the department in order to maximise opportunities for and the quality of student placements. We'll include later on a link to the actual toolkit, which was launched last week, I think. So you can have a look individually and see the things like that. And there's a quick guide of how to use the toolkit, which you could review at a later date if you wanted to. So Callum and I have reviewed the toolkit ourselves, and we've identified 4 main strategies that we think will hopefully help to tackle the problems that we've identified and the members of the MSK team have identified. So the first of these strategies is the development of the induction pack. So I reviewed the current induction booklet that the MSK team have, and we've made some changes to this. Just some updates. So we've updated the pre-reading and revision section of it. So we've added lists of revision topics, common conditions or surgery seen, common assessment techniques used, and the treatment techniques that we've used. So this gives learners the opportunity to prepare for their placement, meaning that they're more confident and hopefully more able to complete more independently earlier, therefore reducing kind of the onus on the educator for teaching. And it also allows that student to develop their own independent study skills. We've included hospital maps. So this seems like a really simple thing to include, but it's just a really useful tool to have as a student and helps to reduce stress and anxiety prior to starting the placement. And it means that they're more, you can focus more on learning rather than being worried about where you need to go, where to park, all of that sort of thing. We've included forms, so the ID badge form, car parking pass and computer access. So this negates the need for this process in the department on the first day, reducing the workload of the educator and the amount of time that it takes to induct a student. And it means that the student can just take some more responsibility from the very start. And we've also tried to develop some additional learning experience pathways. So the idea of this is that there are specific pathways or contacts available within the induction pack to allow students to organise any other additional learning experiences that they would like to complete during their placement. So this could be things like watching surgery, spending a day up on the orthopaedic wards, going to specific classes or clinics within the department, so like TENS, the TENS clinic, or acupuncture or shoulder school. And again, this reduces educator workload, so the students take responsibility for their own learning. The educator's not kind of chasing around trying to organise this for them, and it increases these opportunities for students. So we haven't been able to kind of fully develop these pathways over this placement just because we haven't had much time to do this, but we've included in the induction pack some kind of ideas as to how this can be organised and presented to students, so that hopefully this can be a quick job for someone to do prior to the next students coming in. And then the benefits of all of these, kind of as we've said, it reduces the time that's needed for an in-person induction, and therefore means that potentially another member of the team could do this in-person induction, so one of the therapy assistants, because a lot of the kind of technical aspects of the placement have already been covered. So this reduces educator workload. It also starts to instill self-management and responsibility in the student from the beginning and helps them feel more at ease when they're starting off their placement. And then we just have some additional ideas that you could include within the induction pack or send out or develop yourselves to send out to students prior to the placement. So a meet the team video. So this just will allow students to integrate a bit better and feel more at ease when they start their placement and know who they can go to for different things, so that they're not always feeling the need to go to their educator. So that just helps with that whole team sort of approach. The development of a learning contract. So this details the students' responsibilities, such as organising your own additional learning experiences, things like that, and sets out what's expected of them by when. So by the end of this placement, we expect you to, be able to see a full clinic on your own, or we expect you to be able to see half a clinic on your own. So it means that as a student, you know what you're working towards and you know what your educator is expecting you to be able to do by the end of the placement. And this just allows you to set yourself realistic goals and monitor your own progress independently of your educator. And for more information on this sort of thing, if you have a look at the placement charter, that's got quite a lot of information about this. And also there's a guidance section at the introduction to the Cheshire Merseyside AHP toolkit, the CPEP toolkit, which has got some more information. And then we've also included the development of a learning pack. So this is just a pack that can be sent out to students prior to their placement, and it would include, tables, questions, exercises for the student to complete before and during their placement to record their learning. So for example, prompting for a table that details the main types of surgery seen and the indications for these, or normal ranges of movement values, and area to record different exercises that you've used for different conditions, healing times, things like that. And this will help the student to prepare better for their placement. It reduces the need for formal teaching on placement, because the students can manage their own learning like that, and it can be used in directed study if there's not a large enough caseload for the students to be clinical all the time, so that gives them the opportunity to do that. So I've got an example of this that I was given at Alder Hey, so I'd be happy to share that with people if they want further ideas about how that could be set out and what that kind of looks like.
And for strategy 2, we wanted to utilise timetables and trust laptop. So in the sense, here's an example of a week for a timetable that can be utilised to split the clinic and learning hours equally between 2 students with the 2-to-1 model. So this will aid in splitting attention and caseloads between the two, whilst also helping balance the workload for the educators. And as well as gaining clinical hours, the students will have designated study time and make use of the remote learning resources mentioned in the toolkit. Additionally, students can vary shifts as educators work longer days, and then time can also be spent with other members of the physiotherapy team and the wider MDT, which we'll also talk about in strategy 4. And this can be further facilitated by using Trust laptops. So at present, I believe there's a plan to supply the Trust with more laptops specifically for this reason, and students can loan the laptops during their time on placement should they have limited access to one. And also, I think we've noticed that in some of the clinics, there's limited access to computers, and sometimes you have to delay writing notes and stuff like that. So this would ease the pressure for computers. Notes and records can be done quicker or when they're with the patient. Online education and training can be done easier, and it can be done simultaneously if the students aren't necessarily together in the clinic. And this will also allow the students to complete further learning in the designated study times.
So our third strategy is peer support. So what is peer support? So this is when students are given the opportunity to work with and learn from each other in order to achieve shared aims and objectives. So it just utilises having two students together to offer support and guidance to each other, both in clinical situations and in professional development and reflective practice. So the benefits of this, the students will feel more supported without additional workload on the educator, and they can discuss issues more openly and can learn from each other in a less pressured environment than potentially always being with a qualified physio. It's good for their development and confidence and helps with like well-being and mental health, just to have some additional support there, and potentially may make it easier for them to integrate into the team if they feel like they've kind of got someone that they know already. And this is particularly important because, or as we said, all of those who interviewed felt that the reduced support from a 2-to-1 model would reduce the quality of student placement. So hopefully by utilising peer support, we can overcome that concern. So some ideas of how we can use it. So the students could perform practice assessments or treatments on each other before they do it with patients. They can have student study sessions. So this is where they discuss a case study. This allows learning if the students can't see or do everything together. So say one student saw a really interesting case like a CRPS patient or something like that, then they can go to the other student and teach them about it. So it means that they're not kind of missing out as much on different learning experiences. Students could plan assessments or treatment sessions together and potentially see patients together. So this might mean they can get some independent experience from their educator earlier on, so they've still got some support there, but it doesn't necessarily always have to be with their educator. And the students could work together using during like group sessions such as shoulder school or lower limb group, and can use peer support, reflection and reviewing, and they can do this independently of their educator to give them some admin time as long as they just feed back what they've discussed. And the really great thing about peer support is that this will be there even if no additional steps are made to encourage it. So just it's a natural benefit of having two students on placement together. So any extra focus on this, so using those strategies, is only going to make it better, but it's going to be there no matter what. Obviously, this relies on having both students at the same place at the same time. So this is just something to think about when timetabling, because I know at the moment, Callum and I have not been in the same place at the same time at all. So we potentially haven't been able to use these strategies as much as we maybe could have. So just thinking about with timetabling, it doesn't need to be that they're, you know, together all the time, but maybe trying to think about a few days a week there just in the same clinic so that they can support each other and use this peer support method.
Yeah, and strategy 4 is the whole team approach. So as briefly mentioned on the timetable slide, students could have the opportunity to work with other members of the physiotherapy team and then also other professions that are closely linked with the work that goes on in the outpatients. So for example, any medical staff, advanced practitioners, or even across other departments where AHPs are based. I know this is something that educators try and facilitate a lot with students anyway. So, for example, I've had the opportunity to work with or shadow various members of the physio team and also the MDT during my time with the MSK team over the last couple of weeks. I think this may be something that would need to be a more common occurrence with a 2-to-1 model, and then encouraging the students to sort of take onus on seeking these learning opportunities themselves, just so this will promote independence and responsibility for their own learning, really. And this would benefit as well if sort of clinicalists throughout the physio team could be split and allocated to the students, so you're not just taking your caseload off your educator, you're also helping ease the caseload of every member of the team. And then clinics could also be overbooked, so patients could get seen their own caseload. And then also in terms of feedback, obviously if the students split between a lot of other practitioners, it's hard to assess their progress sometimes. So a student could have a written feedback sheet to help with marking, so the educator sort of knows what the student's been getting up to whilst with other practitioners.
So just summarising kind of the big picture of our ideas and the placement. So using the toolkit, the department will definitely be able to fine-tune their approach to student placement and enable them to take 2 students at the same time. And we definitely believe that this is a possibility. The most important aspect of all of the ideas that we've presented is pre-planning and preparation for students. And once this has been done once and you've developed a good model, you can just use this same model every single time. So it will actually reduce workload and the stress of having students as you go forward. It's really important to utilise the resources that are already available to you. So the whole team approach, the student is not just the responsibility of the educator, everyone is involved in their education and their learning. Peer support and learning together is an invaluable tool and a huge benefit for both the students and department, so it should really be utilised and thought about when you're planning for students. We thought that there should potentially be a bit of a shift from, at the moment, we feel like it's more of a shadowing model that's in place. So the student is sort of paired with one clinician for the day or for the morning or afternoon, and they observe or they treat just that one clinician's list. To, as Callum was saying, sort of a more open model. So there's a lot more flexibility with lists and movement of the student within the day and within a clinic. So this is already in place in other trusts. So I know that at the Royal, they kind of in the morning go through all of the lists and they choose patients for the student to see off all of them, and then the student develops their own caseload of patients, and this just allows more flexibility so that there's not that worry about trying to split one educator's caseload between 2 people. And then we also thought about, we know that some people were maybe reluctant to the 2-to-1 model, but open to having 2 students with 2 educators. So we were just trying to think of some benefits of specifically the 2-to-1 model. And one of the main ones is that it gives educators a bigger gap between students. So you're not always having a student, because I know in our interviews, some of the educators said that they need time to kind of do their own admin and their own additional work rather than always having a student. So by utilising the 2-to-1 model, there's bigger gaps between when you're an educator and when you're not. And obviously that the whole point is that the onus isn't always on that specific named educator to be the only person involved with the students. But by having the 2-to-1 model, it means that you can kind of split up the time where you are that named educator and the time when you're just another member of the team who is assisting that student, but not necessarily doing the marking and the admin associated with that. So to conclude, so what went well? So just some reflections that Callum and I have kind of made over the course of the project. So we followed the quality improvement structure to develop our project. So we defined our problem with clear plans and timelines, and this enabled us to complete the project and to meet our aims and objectives. So we used a targeted approach to the team and their needs. So we really wanted to make this project specific to the department, which we hopefully have done. We individually, we both, I think, developed organisation and our time management skills. So initially we found it quite difficult to sort of completely plan your day, work from home, all of that. But over these 5 weeks, I think we've really developed this, and this is shown through the work that we have been able to complete and what we've been able to do. And we've also been able to successfully work as a team together and with the wider faculty team in order to divide up our workload and our tasks evenly, to work efficiently, and use each other's skills and the resources available to us to kind of make the best of our project. What could have gone better? So we potentially didn't get as many survey responses as we initially wanted to, but we kind of have reflected on that, and we think we only, we left it a bit late. We only gave people a week and we didn't send out any reminders. So in the future, we would think about that more clearly when we're planning our project timelines. We were potentially slightly limited by the hybrid aspect of the placement. So if we'd have been on this full time, we could have kind of developed it further. We missed some opportunities, such as talking to managers and things like that. But I think the hybrid model of this placement really gave us obviously clinical experience within the specific department, which means that we were able to really target our ideas through our own lived experience of being a student on that placement. And we were also unable to work together on things in person due to obviously COVID and social distancing. So it would have been good to maybe practice things or just go through ideas more easily if we'd have been able to be on site doing the project. And then further ideas for development. So this list is just sort of recommendations for future work by the faculty, other students and the MSK department. So an issue that came up is that each uni has different sort of demands and marking criteria and schedules for feedback. So this can make it challenging for students, particularly if there's maybe two students from different universities at the same time. So at the moment with me and Callum, so we thought maybe there could be a consideration of some standardisation of the university marking schemes between the unis in the area to make it easier on placement providers. The development of the additional induction resources that I talked about earlier, and the development of those formal additional learning experience pathways that we weren't quite able to do during our placement, but we've kind of given the ideas are there.
Yeah, so thanks everyone for attending the presentation this morning, and we hope it's been informative for you. What we've done is we've created a link that's available here, so you can scan the QR code or click the link, and it'll send you to a really quick feedback survey just to let us know how you thought we got on. We'd really appreciate this because you're taking the time to do this, as it would aid our learning greatly. And then also we'll be sending the MSK team the same survey as we previously did, just to assess the effects of the presentation and the project. Again, if you have the time to fill this out, it'll be greatly appreciated. Yeah, and we'd like to open up to any questions you have regarding what we've spoken about, and we also have Nisha, Charlotte and Graham here from the faculty who can help answer any of your queries.
So I think we've got a hand up from Amanda Deves.
Hi, Ellie and Callum. Thank you very much, and well done the pair of you. That was really interesting, and you've clearly put a lot of work into that. That was kind of going to be my question. Obviously, you've said that you were on the hybrid model, but how much time were you doing this project, and how much time were you doing clinically?
So we had 3 days clinically within the MSK team and then 2 days on the project. So we've tried to sort of stick to those working hours of doing 8:30 to 4:30 at home on the project, but I think we've both maybe, especially last week, done a little bit more than that just to get our PowerPoint finished and sort of all done for today. But we really tried to stick within that time frame to kind of get the good work-life balance that is sometimes tricky when you're working from home.
Yeah, well done. You've obviously put a lot of time and effort into that and followed through the model really well. Just a minor point, the universities in the Northwest do use the same marking scheme, but we do deliver them on different platforms. So that might be where educators get a little bit confused over the wording and what's going on, but that's a deliberate thing to hopefully reduce the workload for the educators. perhaps we as HCIs need to do a little bit of work to reassure people across the region that it is actually all the same marking criteria regardless of where the students are coming from. But well done, very interesting, lots of food for thought again, thank you.
Thank you.
Thank you. Trying to work out who's got their hand up. Lucy O'Driscoll.
Hi, Ellie and Callum. Thank you very much. That was an amazing presentation. I just want to say that start off, I've been working on this project for 6 months, and honestly, you summarised it far better than I could have done after all this time. So it was brilliant, really well done. I just wanted to ask you a couple of questions. I'm hopefully going to steal some of your ideas when I go back to your day job, if that's okay with you both. So I wanted to ask you about, you talked a little bit about the structured questions you went through with the department. Do you find that those structured questions, do you think it came better being asked by somebody that wasn't within the department? So going in as students, do you think you got more honest and open replies than you would have done if it had been asked by somebody that worked within the department? Does that make sense?
Yeah, I think especially with the clinicians, I think we got quite honest responses. And I don't think they'd mind us saying that a lot of it was they're quite skeptical of the idea, and they focus a lot on sort of the barriers of sort of what would hinder having a 2-to-1 model and stuff like that. So that's what we wanted to focus on, really. They were really honest with us, so we wanted to make the presentation really informative and make sure that we covered all of their concerns, really.
That's great, thank you.
Nisha.
Thanks. That was a great presentation, guys. I'm biased, I know, but that was amazing. I just wanted to put it out there that this was very much a first hybrid model that we'd done, obviously, in the faculty in terms of a leadership placement along with the MSK team. So it was a learning curve for all of us. And it was very much a co-production, as in Ellie and Callum helped to design the placement. I think Charlotte and I and Danielle and Dave on the MSK side, it was very much we were directed by how they shaped that placement. So that was a great tip for us to take away, that these placements are going to be very much co-productions. They are in partnership with our learners rather than us directing them as educators. So well done, guys. That was amazing.
Thank you.
Thank you.
Yeah, I just wanted to say well done as well. Really, really good.
Thanks very much.
I know it's kind of nearly, obviously we're only scheduled until 12. I'm just trying to see if there's anyone new that's put their hand up for a question. Jane Hall.
Hi there. Yeah, I'm Jane, CPEP lead from across the border in Greater Manchester. So definitely well done on your talk. I suppose I also take students on leadership placements, and I think amongst the student group, there's still a bit of uncertainty about what these placements are and what the benefits are. Have you found that with your peer colleagues? Like what do you chat about when you say I'm on a leadership placement? What's the response you get from your colleagues?
I think most people are like, oh, just don't know what it is. And I think particularly in my year group, the kind of focus has been on all clinical work and clinical placement. So I think people are like, oh, are you worried that, you're not going to have as much clinical experience and you're not going to be as good of a physio because you haven't had as much time clinically. But I think when you kind of explain to them actually what we're doing, and I think it does benefit your clinical work as well, because you know more about what's going on behind the scenes and you have a better appreciation for like the quality improvement initiatives and how that actually works. So then going into the world of work, your life isn't all just going to be clinical and seeing patients. You have to be involved in the wider aspect of the NHS. So I think it's actually been really beneficial.
Yeah. I think as well, for myself, I got the placement quite last minute, so I was quite unsure myself on what to expect. And when I've told people on my course, they were the same. They had no idea what it was about. So I think if like in the future, if we try and propagate awareness to the universities that these placements, you have the potential to go on placements like this, and then people could also volunteer for them who want to gain skills like that. It'll be really good.
Yeah, I agree. There's a bit of work to do about student preparedness and awareness from the student body side. But yeah, at the moment, you're the trailblazers. You're going to be standing out when you become qualified therapists. So yeah, great. Thank you.
Thanks.
So I can't see any more hands up.
Thanks,
Simon.
Yeah.
Oh, cheers. Thanks, Ellie. Callum. Can only echo what everyone said about your presentation. Really good. I was maybe just, if it's the last question, going to ask you again, if you don't mind, to maybe as a take-home message to summarise to us what you think you've learned from doing it and being on this placement.
Okay, so I think the main thing is kind of, obviously I was quite skeptical about it as well, but I think going into things with an open mind and just sort of using it as an opportunity rather than seeing it as, you know, maybe a barrier to your clinical work, and thinking, I think all along the way thinking, how can I use this to help my clinical work rather than this is hindering my clinical work. And then I think in terms of our actual project, I think hopefully we've been able to benefit the MSK team and to help future students and potentially develop a better model of placements to allow them to take on more students, which will then hopefully ease the work for the unis and for kind of the future placement coordinators to find placements for the students.
Yeah, definitely. And I think as well as, I think every student has a different sort of attains different skills because they all have different clinical experiences on placement. But I think because we've had the unique opportunity to do something like then we have sort of unique skills that we can bring into being a newly qualified Band 5 that a lot of the people wouldn't necessarily have.
And I think particularly because I think we're both planning on working in Merseyside after we graduate, then we'll be directly affected by the faculty and potentially continue to be involved in the work that they're doing. So this is a really good stepping stone for that, for when we qualify.
Yeah.
Okay. So yeah, I know we only have about like 10 minutes left. So if there's no other questions, we'd just like to remind everyone to try and fill in that feedback form if possible. And just thank you very much for coming.
Yeah, thanks very much, guys.
Oh, I couldn't click on it because it was on the PowerPoint. If you're able to cut and paste it into the chat now, I can do it for you if that's okay. Sorry, I meant to say that before, but it went out.
Oh yeah, I'll do that.
Thank you.